I would like to end the discussion here talking a little bit about the next step in research around the BCMA-targeted therapies in relapsed refractory. So where do you see the ongoing challenges being, if you look at the studies, if you look at the data and your own experience, where do you see the big hurdles?
I think the biggest hurdle I see for myeloma treatment in general is one and done therapy, meaning I don't want to ever have to tell a myeloma patient, you have to come back to me every month. And so if we can figure out a way to get a durable response without having to have the patient come back forever, that would be a huge win. And some of the things that may help us there, for example, some of the CAR T patients have had long-term outcomes, not all, some few hand-selected have had those. And if they have, we need to figure out why they had it. We need to do good correlative studies to understand that, pick patients appropriately, maybe move those therapies more forward in their treatment time so that we're not using exhausted T cells. The BCMA ADC study actually treated people for 16 cycles. They did allow some people to stay on, but the point of that is that there were people that got limited cycles and still benefited, and I think that's really important too. And I think that's going to be something ultimately the bispecifics will deal with. Are they going to be giving therapy forever or not? So I think we have to remember that these myeloma patients are coming to us, as you said, for 10 years, and we don't want to make them come all the time. We love seeing them, but not necessarily they love seeing us every month. So we want to make sure that we make it something that maintains their quality of life.
To make sure we cover all the bases, we have talked about the DREAM program for the BCMA-targeted ADCs. Are there any other drugs in development targeting BCMA that are ADCs?
I don't know of any other drugs that are targeting BCMA for ADC. There's the bispecifics, which we haven't talked too much about, and we can talk a little bit about them, but for the bispecifics, we know that there's the only public data that's been available was the Amgen 401 experience, and it was a continuous diffusion bispecific. Because of that, I think that it's no longer being developed because it's hard to do that. But it did show some preliminarily efficacious results. I believe 7 out of the 10 people at their MTD did have a response with some CR. So it's promising for sure, but I think we have to make it user-friendly. Like you said, people are on therapy for a long time, and they don't want to be hooked up to an IV every day.
I think I agree with you that the bispecific BCMA-targeted therapies are very interesting. I looked in preparation for today a little bit into the presentations that are around ASH 2019 and looking online. I think Amgen, as you pointed out, the 420, that seems to have been terminated, but they also in the public domain are developing this potentially for subcutaneous use. They have the 701 drug, that's an infusional therapy. And then Celgene has also their BCMA CD3 targeted therapy that's presented at the ASH 2019. And then in addition, Janssen has another drug, and Pfizer has also a drug for BCMA CD3. So there may be additional I did not read up on.
Yes, there's
but
a few
I think
others.
the message is that there are very many of these bispecifics, but I think there is only one, as you point out, BCMA targeted ADC drug.
Yeah, for now, yeah.
For now.